HSIL in Cervical Cytology vertical bar Bethesda criteria, Morphology, Differential diagnosis and Pitfalls. What HSIL actually means. HSIL stands for high-grade squamous intraepithelial lesion. In the Bethesda System, it is a cytologic interpretation used when squamous cells show convincing abnormalities sufficient for a definitive high-grade diagnosis. The category encompasses cytologic changes traditionally associated with moderate and severe dysplasia, carcinoma in situ, and SIN2 and SIN3. These terms must remain conceptually separate. HSIL is a cytologic interpretation, whereas SIN2 and SIN3 are histologic diagnoses based on tissue architecture. HPV testing represents a separate molecular assessment and does not determine the cytologic category. The critical diagnostic threshold is between ASC-H and HSIL. ASC-H indicates genuine concern for HSIL, but insufficient findings for a definitive diagnosis. HSIL requires unequivocal integrated high-grade squamous morphology. These categories represent different levels of diagnostic certainty, not sequential stages of biological progression. Core cytomorphology of HSIL. HSIL most commonly involves small, relatively immature squamous cells with reduced cytoplasmic maturation. The cytoplasm is scant, producing a substantially increased nuclear-to-cytoplasmic ratio. However, a high N:/C ratio alone does not establish HSIL. Immature metaplastic cells and parabasal cells normally have relatively high NC. The important question is whether the N:/C ratio is inappropriate for the cell type and degree of maturation. The nuclei provide the most important diagnostic abnormalities. They are typically hyperchromatic with irregular nuclear contours, which may show indentations or grooves. Chromatin may be fine or coarsely granular but is abnormally distributed. Nucleoli are generally absent or inconspicuous in classic HSIL, although their presence does not absolutely exclude the diagnosis. Absolute nuclear size is less useful than the relationship between nuclear size, cytoplasmic volume, maturation, nuclear contour, and chromatin. HSIL cells may actually be smaller than LSIL cells because progressive loss of maturation reduces cytoplasmic volume. Architecture is variable. HSIL cells may occur singly, in sheets, small groups, or syncytial hyperchromatic crowded groups with poorly defined cell borders. Crowding or hyperchromasia alone is not diagnostic. Genuine nuclear abnormalities must be identifiable. Therefore, HSIL is an integrated cellular phenotype, loss of maturation, an inappropriately increased N:/C ratio, and convincing high-grade nuclear abnormalities must be interpreted together. HSIL versus ASC-H. The most important diagnostic threshold for HSIL is its distinction from ASC-H. Both may contain small immature, squamous, or metaplastic type cells with increased NC, hyperchromasia, irregular nuclear contours, and abnormal chromatin. In ASC-H, genuine concern for HSIL exists, but some component remains insufficient. The suspicious cells may be poorly preserved, nuclear contour or chromatin abnormalities may be equivocal, or the abnormal population may be extremely limited without sufficient well-preserved morphology for confident interpretation. In HSIL, the high-grade abnormalities are unequivocal and occur together in cells whose complete phenotype supports a definitive high-grade lesion. Importantly, cell number alone does not determine ASC-H versus HSIL. Rare well-preserved cells may justify HSIL when their morphology is unequivocally high-grade. Conversely, numerous dark or crowded cells should not be called HSIL when their nuclear features cannot be adequately evaluated. The practical distinction is genuine concern for HSIL, but insufficiently convincing high-grade morphology, ASC-H, unequivocal integrated high-grade squamous morphology, HSIL, HSIL versus LSIL. LSIL typically involves mature superficial or intermediate type squamous cells with relatively abundant cytoplasm and retained maturation. HSIL more often involves smaller, less mature cells with scant cytoplasm and a substantially increased N:/C ratio. Although both may show hyperchromasia, nuclear contour irregularity, and abnormal chromatin, these abnormalities occur within different cellular phenotypes. Importantly, an HSIL nucleus does not necessarily have to be larger than an LSIL nucleus. The striking N:/C ratio in HSIL may result substantially from reduced cytoplasmic volume and loss of maturation rather than simply greater nuclear enlargement. Coilocytic change may support LSIL, but coilocytosis does not by itself determine lesion grade. The practical distinction is mature squamous phenotype with convincing low-grade nuclear atypia LSIL, loss of maturation with substantially increased N:/C ratio, and unequivocal high-grade nuclear atypia HSIL. Major benign mimics and diagnostic pitfalls. The major benign mimics include immature squamous metaplasia, atrophy, reactive or reparative change, degeneration, and hyperchromatic crowded groups. Immature squamous metaplasia is particularly important because these cells naturally have relatively high NC and may occur in cohesive groups. A benign interpretation is favored by cellular uniformity, smooth nuclear contours, fine chromatin, and orderly cohesion. HSIL is favored by genuine nuclear membrane irregularity and abnormal chromatin within an abnormal high-grade population. In atrophy, parabasal cells naturally have scant cytoplasm and high NC. Degeneration may additionally produce hyperchromasia, pycnosis, or smudging. Therefore, small dark cells in an atrophic preparation should not automatically be interpreted as HSIL. Well-preserved nuclei must demonstrate convincing high-grade abnormalities. Reactive or reparative cells may show nuclear enlargement, crowding, and occasional hyperchromasia. Relatively smooth nuclear membranes, open or evenly distributed chromatin, cohesive or streaming architecture, and prominent nucleoli in the appropriate context favor repair. Prominent nucleoli support a reactive process but do not absolutely exclude HSIL. Degeneration and poor preservation may produce dark, distorted nuclei, while benign cells may form hyperchromatic crowded groups. Neither darkness nor crowding establishes dysplasia when nuclear detail cannot be reliably assessed. HSIL versus squamous cell carcinoma. HSIL must also be distinguished from invasive squamous cell carcinoma. Features increasing concern for invasion include greater cellular and nuclear pleomorphism, bizarre cell forms, abnormal dense keratinization, and tumor diathesis composed of necrotic debris and degenerated blood. Keratinizing carcinoma may contain elongated spindle, fiber, or tadpole-shaped malignant cells. However, keratinization or tumor diathesis alone does not establish invasion. Cytology cannot directly demonstrate stromal invasion because tissue architecture is unavailable. When unequivocal HSIL contains additional features concerning but insufficient for invasion, the Bethesda System permits the qualification HSIL with features suspicious for invasion. The practical distinction is HSIL morphology without convincing evidence of invasion HSIL, HSIL with concerning but insufficient features of invasion, HSIL with features suspicious for invasion, overt malignant squamous cytomorphology, squamous cell carcinoma, practical microscopic approach and diagnostic pitfalls. When small atypical squamous cells are encountered, begin by identifying the cell type and degree of maturation. Determine whether the cells are immature, metaplastic, parabasal, or a genuinely abnormal immature squamous population. Next, confirm that preservation permits reliable nuclear assessment and determine whether the N:/C ratio is genuinely abnormal for that cell type. Then assess the nucleus. Evaluate nuclear contour, chromatin distribution, hyperchromasia, and nuclear size together. Next, assess architecture and population context, including isolated cells, sheets, small groups, or crowded syncytial aggregates. Finally, ask whether immature metaplasia, atrophy, reactive change, degeneration, poor preservation, or another benign process adequately explains the findings. The practical threshold is adequately explained by a benign or reactive process, benign or reactive, genuine concern for HSIL, but insufficient high-grade morphology ASC-H, unequivocal integrated high-grade squamous morphology HSIL. Several shortcuts must be avoided. A high N:/C ratio alone does not establish HSIL. Small dark cells alone do not establish HSIL. Hyperchromasia alone does not establish HSIL. Cellular crowding alone does not establish HSIL. Conversely, rare cells should not automatically be downgraded when their morphology is unequivocally high-grade. Reporting, HPV, and clinical significance. Under the Bethesda System, the appropriate terminology is high-grade squamous intraepithelial lesion HSIL. HSIL remains a cytomorphologic interpretation. SYN2 and SYN3 are histologic diagnoses, while HPV testing provides molecular risk information. HSIL is strongly associated with high-risk HPV infection, but HPV status should not replace morphology. HPV positivity does not convert insufficient cytomorphology into HSIL, while an HPV negative result should not erase unequivocal high-grade morphology. HSIL carries substantial clinical significance because of its association with underlying high-grade cervical precancer. However, management remains separate from the cytologic diagnosis and is risk-based, incorporating factors such as age, HPV findings, and previous screening history. The central diagnostic principle remains morphological. HSIL should be reported when sufficiently preserved squamous cells demonstrate an unequivocal integrated high-grade phenotype characterized by loss of maturation, an inappropriately increased N:/C ratio, and convincing nuclear abnormalities that cannot be adequately explained by a benign or reactive process.